Hello, everyone, and thank you for being here. My name is Angela Williams, and today we're diving into a powerful case study on HIV/AIDS. Not from a textbook or a big country, but from Eswatini, one of the smallest nations in southern Africa. Despite having the highest adult HIV prevalence in the world, this country has achieved remarkable progress. Over the next 25 minutes or so, we'll explore what's working, what's challenging, and what the global health community can learn from Eswatini's response to HIV. To guide our time today, I've laid out 6 objectives that will shape the flow of this presentation. First, we'll describe the basic demographics and health landscape of Eswatini to set the context. Then, we'll dive into the scope of the HIV epidemic, how widespread it is, what's driving it, and who's most affected. Third, we'll interpret the trends in data, looking at progress toward major benchmarks like the UN/AIDS 95-95-95 targets. After that, we'll review how treatment is provided, with a focus on ART access and medical infrastructure. Fifth, we'll explore Eswatini's multi-layered prevention strategy, which includes biomedical tools like PrEP and behavioral interventions like school-based education. And finally, we'll evaluate the barriers that remain, like funding, reliance, stigma, and youth outreach, and discuss what future progress could look like. Let's get started. So, why focus on Eswatini? And why now? HIV/AIDS continues to be one of the most urgent public health issues worldwide. Among all countries, Eswatini has faced some of the highest rates of HIV. Nearly 1 in 3 adults aged 15 to 49 live with the virus. But this isn't just a story of hardship. It's also a story of resilience, innovation, and measurable progress. Despite limited resources, Eswatini has become a leading example of how to mount an effective, science-driven response to HIV. Today, we'll look at how this small country is making big strides, from policy changes and medical access to bold community action and strong international partnerships. Our goal is to understand both the scale of the challenge and the power of a coordinated, evidence-based public health strategy in overcoming it. We'll also explore how global health priorities intersect with local realities, and why Eswatini's approach may offer valuable lessons for other high-burden countries. By the end of this presentation, you'll have a deeper appreciation for the many layers of Eswatini's HIV response and the critical work still ahead. Before we dive deeper into HIV, let's get a sense of Eswatini itself. This landlocked nation lies between South Africa and Mozambique. With a population of around 1.2 million, in an area just over 17,000 square kilometers, it's one of the smallest countries in Africa. Most people live in rural areas where reaching healthcare facilities can be difficult. The average life expectancy is around 59 years old, though that is steadily improving thanks to better access to HIV treatment. Eswatini's gross national income per capita is approximately $4,000, but significant income inequality and widespread poverty still persist. Over 60% of the population lives below the national poverty line, and many rely on subsistence farming. The majority of citizens rely on the public health system, which is under pressure by heavily supported by global funding resources, especially in the HIV response. Traditional gender roles and strong cultural heritage also shape health behaviors and access. Understanding these social and economic realities helps us grasp why public health strategies need to be tailored, inclusive, and sustainable. Now, let's take a look at the numbers to get a clearer picture. As of 2022, about 27% of adults aged 15 to 49 years old in Eswatini were living with HIV, translating to roughly 210,000 individuals. However, progress has been remarkable. Since 2010, new infections have dropped by over 60%, going from 10,000 cases a year to just under 4,000 cases a year. Age-related deaths have also declined, from around 9,000 in 2005 to about 2,800 in 2022. These changes aren't just numbers on a chart. They represent thousands of lives saved, families kept together, and a health system that's evolving to meet the needs. This country's ability to bend the curve of the epidemic is rooted in aggressive data use and consistent monitoring. Surveillance efforts, demographic health surveys, and targeted evaluations allow Eswatini to adjust strategies quickly. Even so, infection rates remain highest among women and young people. These populations require tailored interventions if the country hopes to end this epidemic. That brings us to a really important question. What's driving the epidemic? Understanding the drivers of HIV in Eswatini requires looking beyond medicine. While the main route of transmission is heterosexual sex, accounting for over 90% of new cases, it's the structural and social conditions that fuel vulnerability. Widespread poverty, gender-based violence, transactional and intergenerational sex, and gender inequality all play a role. Cultural norms and stigma make it harder to discuss or disclose HIV status, especially for young people. Women, particularly adolescent girls and young women, are disproportionately affected, making up around 60% of all people living with HIV. This is tied to power dynamics, limited access to education, and economic dependence. Pediatric HIV remains a concern as well, with about 3,000 children under 14 infected, mostly through mother-to-mother transmission. Addressing these issues requires more than just medication. It demands social transformation, gender-sensitive programming, and targeted economic support for vulnerable families. Now, let's look at a key data visualization. This bar chart, titled 2021 HIV Prevalence Among Adults, provides a snapshot of how HIV prevalence varies across age groups, and importantly, how it differs between men and women. On the y-axis, we see the percentage of adults living with HIV, while on the x-axis, this breaks the data down into age categories, starting at 15 to 19 years of age and going all the way up to 65 years old and older. Each age group includes two bars, one for women and one for men. This way, we can easily compare gender differences at each life stage. What immediately stands out is the stark contrast in prevalence between genders. In every age group, women have significantly higher HIV prevalence rates over men. For example, in the 35 to 39 year age group, more than half of women, exactly 52.5%, are living with HIV. This is compared to just under 27% of men in that same group. That's a powerful statistic. You'll also notice that HIV prevalence among women spikes so much earlier, with sharp increases beginning in the 20 to 24 year and 25 to 29 year age brackets. For men, the increase is more gradual and generally peaks later. This reflects gendered patterns of vulnerability and exposure. Women, especially young women, face a combination of biological, social, and economic risk factors that make them disproportionately affected. Another feature of this chart is the error bars. These represent 95% confidence intervals. They give us a sense of the statistical certainty behind each data point. So, while the bars show the best estimate, the error bars help understand the possible range where the true prevalence likely falls. In most cases, even accounting for the margin of error, the gender gap remains clear and significant. Lastly, the table beneath the chart provides the exact percentages for each group, making it easy to reference. Overall, this chart helps tell a critical part of the HIV story in Eswatini. While the epidemic affects both men and women, young and middle-aged women are especially impacted. Interventions need to be tailored accordingly. It also reminds us of the importance of age and gender-specific programming while designing interventions. This also includes testing and treatment efforts. Despite the heavy burden of disease, Eswatini has become a public health success story in many ways. Through aggressive testing, treatment, and prevention efforts, the country has nearly achieved the UNAIDS 95-95-95 target. By 2022, 95% of people living with HIV knew their status. 92% of those were on antiretroviral therapy, also known as ART, and 89% of those on ART were virally suppressed. That's a major accomplishment. These figures show the real-world impact of policies that prioritize universal access to care. Routine testing has become part of antenatal care, workplace screenings, and even door-to-door outreach. Peer support groups and expert clients have been instrumental in helping people stay on treatment. This comprehensive system of care is making a difference, but continued progress demands on keeping people engaged, especially in remote areas and among mobile populations. Let's take a closer look at this chart. It gives us a powerful visualization of where Eswatini stands in terms of HIV awareness and treatment across different age groups and between men and women. This chart breaks the population of adults living with HIV into 3 distinct categories. First, we have those who know their HIV status and are on treatment. These are shown in dark green. These individuals are actively managing their health with antiretroviral therapy, also known as ART, which helps suppress the virus and prevents transmission. Then, there's a group in light blue. These people are also aware of their status, but for some reason they're not on treatment. This could be due to a number of factors like access issues, stigma, or personal choice. Finally, the light green segment show those who are living with HIV but don't yet know their status. These are the most at risk for late diagnosis and unknowingly passing the virus on to others. Now, as we move across the chart, we can see the trends by age. In the younger age groups, like ages 15 to 19 and ages 20 to 24, there's a much higher proportion of individuals who are unaware of their status, especially among men. That's concerning because early diagnosis is critical for long-term health and prevention. On the other hand, as we move into the older age brackets, especially ages 35 to age 49, you'll notice a shift. More people know their status and are on ART. That's exactly what we want to see. When we look at gender differences, women generally show higher rates of awareness and treatment across almost all age groups. This may be partly due to frequent testing during antenatal care or targeted outreach efforts. Men, particularly younger men, tend to lag behind, highlighting a key gap in the response. Overall, this chart reinforces two important takeaways. One, we need to ramp up HIV testing among young people, especially men. And two, knowing your status is only the first step. Getting on and staying on treatment is just as critical for both the personal and public health. When it comes to treatment, Eswatini is doing a lot right. Antiretroviral therapy, also known as ART, is provided free of charge through the public health system. Care has become more accessible thanks to decentralization. ART is no longer just available at central hospitals, but can be accessed through rural clinics and community-based ART groups. They've also adopted multi-month dispensing, allowing patients to receive several months' worth of medication in one visit. Differentiated service delivery models are helping patients manage their own care with dignity and flexibility. Teen clubs, community adherence groups, and family-centered care models have also proven effective. However, this process depends heavily on external support. The majority of the HIV response, including medications, training, and infrastructure, is funded by international donors like PEPFAR and the Global Fund. If that support were to decline, the health system would face serious risks, especially for marginalized groups who rely most heavily on public programs. As we know, prevention is key, and Eswatini has invested in a multi-pronged biomedical approach. First, HIV testing and counseling, also known as HTC, is widely available, often delivered through mobile units, door-to-door visits, and outreach programs. Second, pre-exposure prophylaxis, also known as PrEP, is being provided to high-risk groups, including sex workers, young women, and men who have sex with men, also known as MSM. Third, voluntary medical male circumcision, also known as VMMC, has reached over 70% of eligible men, reducing their risk of acquiring HIV by about 60%. And finally, the prevention of mother-to-child transmission, also known as PMTCT program, has seen major success, ensuring that HIV-positive mothers receive treatment that drastically lowers the chance of passing the virus to their babies. These interventions are effective because they are delivered where people live and work. Expanding access to HIV self-testing kits and integrating prevention strategies into everyday healthcare visits are key next steps to increase reach and impact. While biomedical tools are essential, changing behavior and structural conditions is equally as important. Eswatini supports a range of behavioral interventions, such as peer education, school-based sex education, and youth-friendly clinics. Community-led initiatives help reduce stigma and build trust, especially among vulnerable populations. There's also a strong push for general equality. Programs that empower women economically and socially are helping to reduce dependency and risk. Free condom distribution, youth clubs, and safe spaces for girls are examples of how public health can intersect with community development. Laws protecting people living with HIV and campaigns that promote human rights also help reinforce these behavioral changes. Behavior change is a long-term process, and Eswatini is taking steps in the right direction. Eswatini's progress wouldn't be possible without robust donor support. Programs from PEPFAR, the Global Fund, and UNAIDS provide not just funding, but also technical expertise, staff training, and strategic guidance. These partnerships have helped Eswatini build a stronger health system and expand access to services. However, this heavy reliance on donors presents a vulnerability. As global health priorities shift, there's no guarantee that funding levels will remain the same. That's why Eswatini and its partners are increasingly focused on sustainability, exploring ways to diversify funding sources, increase domestic investments, and build local capacity for long-term success. Strengthening national health insurance schemes and leveraging public-private partnerships are potential pathways to reducing donor dependency while maintaining progress. Even with all of this progress, serious challenges still remain. Youth engagement is inconsistent, and HIV-related stigma continues to be a major barrier to testing and treatment. Many rural communities still struggle with access to care due to geography, infrastructure, and staffing shortages. The over-reliance on external funding also makes the system vulnerable to global economic and political shifts. Looking ahead, Eswatini must prioritize expanding the health workforce, improving mental health services for people living with HIV, strengthening its data and surveillance systems, and investing in homegrown innovations. Building public trust, integrating HIV services into broader health services, and addressing social determinants of health are essential to long-term success. The future depends on Eswatini's ability to be resilient, self-reliant, and inclusive. Let's wrap up. Eswatini has shown the world what's possible. Even with limited resources, they've reduced HIV incidence and deaths, expanded art access to near universal levels, and launched effective prevention campaigns. Now, it's time to sustain and build on that. Recommendations: to prioritize youth-centered programming, expand domestic funding options, invest in mental health, and continue fostering community ownership. If Eswatini stays the course, it can become a model for ending the HIV epidemic. Here are all of my references. Does anyone have any questions? That's a great question. So, what's driving the higher HIV rates among young women in Eswatini? Well, there are a few important reasons. First, there's the biological aspect. Women are more vulnerable to HIV transmission during heterosexual sex. But more significantly, the difference is shaped by social and economic conditions. Many young women engage in relationships with older men, maybe for financial support, which could increase risk due to power imbalances and lower likelihood of condom use. There's also gender inequality, which limits access to health education and services. Women often don't have the same agency to make decisions about their sexual health. So, while the statistics show a clear gender gap, it's the result of a couple complex mixes of cultural, economic, and structural factors that disproportionately affect young women. Thank you for that question. Does anyone else have any questions? Another excellent question. You asked, what efforts are in place to reduce the number of people who are unaware of their HIV status, particularly among young people? So, Eswatini has actually been working hard on this front. One of the main strategies is community-based HIV testing, where health workers go directly into communities and schools to reach people who might not go to a clinic. There are also youth-friendly services being rolled out, which aim to create safe, welcoming environments for young people to get tested and learn about prevention. Additionally, HIV self-test kits are becoming more accessible. These allow individuals to test privately and on their own time. Programs are also pairing testing efforts with education and peer outreach, so young people can hear from others their age about why knowing your status is important and empowering. The goal is to make HIV testing feel normal, accessible, and judgment-free, especially for youth. Thank you both for your questions. Thank you all so much for your time, attention, and engagement today. Eswatini's experience with HIV is more than just a health story. It's a story of strength, innovation, and determination in the face of adversity. From some of the world's highest prevalent rates to groundbreaking progress in testing, treatment, and prevention, Eswatini has proven that change is possible, even under challenging conditions. Their success shows the impact of combining global support with local leadership and what can be achieved when communities are empowered to take charge of their own health outcomes. As we reflect on today's presentation, I hope you walk away with not just facts and figures, but with an appreciation for the human effort behind every success statistic. Public health is about people, the health workers, the policymakers, peer educators, and individuals living with HIV who continue to show what resilience truly means. Please feel free to reach out if you have any questions, comments, or would like to discuss any part of today's topic further. I'd love to hear your thoughts and continue the conversation. Once again, thank you. And let's keep striving toward a future where HIV is no longer a global threat, but a challenge we overcome together. Thank you.